Toha Bhuiyan, who is part of the Refugee Relief and Repatriation Commission in the government of Bangladesh. Welcome, Dr. Bhuiyan.
Distinguished colleagues, partners, and members of Global Health Community for Global Hepatitis Elimination, Assalamu alaikum, and warm greetings from RRC office and as well as Government of Bangladesh. I am honored to speak today on behalf of the Refugee Relief and Repatriation Commission, Bangladesh, as we address a critical yet often under prioritized of Commission, Bangladesh, as we address a critical yet often under prioritized issue, hepatitis C among Rohingya refugees in Cox's Bazar. The Rohingya crisis remains one of the largest protracted humanitarian emergencies in the world. Nearly 1 million forcibly displaced Myanmar nations reside in the extremely dense camp settings. These conditions, overcrowding, limited specialized healthcare services, and high vulnerability create a fertile ground for silent epidemics like hepatitis C. Recognizing the gravity of this challenge, the government of Bangladesh, through the Rohingya Refugee Relief and Repatriation Commission, has demonstrated strong political commitment by establishing a dedicated hepatitis C task force in Cox's Bazar. This task force brings together government authorities, UN agencies, NGOs under the unified coordination framework led by RRC, ensuring the policy decision, resources, mobilization, and the programmatic responses are aligned with the accountable. The RRC office has played a central conveying role, working alongside the health sector to oversee program expansion, quality assurance, and data governance across all of the camp settings. According to global estimates from the World Health Organization, over 58 million people live this chronic hepatitis C, with approximately 1.5 million new infections annually. In humanitarian settings, the burden is often underestimated due to limited surveillance in Cox's Bazar camps. Emerging programmatic data and targeted screening suggests the hepatitis C prevalence may be higher than the national average of Bangladesh, particularly among adults with prior unsafe medical practices, individuals exposed to unregulated blood transfusion, and the population with the limited awareness of transmission routes. To put this perspective, while the general host community in Bangladesh carries the hepatitis C prevalence of only 0.2 to 1, prevalence among the Rohingya population, the Cox's Bazar ranges is 13.2 to 19.6%, and among the pregnant women, it reaches high as 15%. They tell us that this community carries this appropriate and devastating burden that demands urgent, targeted, and sustained action. It is this stark contrast and that makes the Rohingya population epidemiologically unique and morally impossible to overlook. There is a small history. Government of Bangladesh first start treatment 2018 treatment of hepatitis C 2018. First 500 patient. Then MSF started their journey from 2019, and it is maybe more than 30,000 now. Key challenges. The response to hepatitis C in this setting faces two key challenges. First, infection prevention risks persist as inadequate sterilization practice, informal healthcare providers, lack of community awareness continue to fuel transmission. Second, stigma and awareness barriers cause many individuals to delay or avoid care altogether, fearing social consequences of a positive diagnosis. Our strategic response. Under the leadership of Government Bangladesh, and RRC, in collaboration with partners such as UNHCR and WHO, we are advancing a multiple pronged strategy. On the prevention front, we are strengthening infection prevention control across the health facilities, ensuring safe blood transfusion system, and delivering community level awareness campaigns through trained volunteers. For screening and early detection, we have integrated hepatitis C testing into primary healthcare services, introduced targeted screening for high-risk population, and deployed rapid diagnostic tests situated to camp settings. On treatment and care, we are scaling up access DAS, DAAS, developing referral pathways for complicated liver disease, and building the capacity of healthcare workers in hepatitis C case management. Finally, we are strengthening health information system for case tracking and monitoring, fully aligned with the WHO Hepatitis Elimination Strategy 2030. A landmark program from diagnosis to treatment. On 6 March 2024, WHO and aligned with Bangladesh government launched the first formal hepatitis C treatment program in the Coxbazar camps, marking a historic milestone in the humanitarian health response. The program began with 2 treatment centers established by IOM, MSF, Save the Children, SCI, and has since expanded to 9 centers across the camp. This expansion reflects the strong coordination and unwavering commitment of all partners involved, anchored by the health sector and the RRC office, which have maintained a robust coordination architecture and ensures seamless referral pathway and accountability of every level. What makes this program truly remarkable is its scope and significance. This is the first end-to-end hepatitis C initiative in the WHO Southeast Asia region CRO, spanning the full continuum from the diagnosis to treatment, and it is operating in what is recognized as one of the highest burden humanitarian setting in the world. The program has adopted a powerful integrated care model alongside hepatitis C. All screening centers now test for hepatitis B, syphilis, and HIV, ensuring that no co-infection is missed and that patients receive holistic, dignified care in a single visit. Every health facility across the camps serves as an active screening point, with rapid linkage to care as a core operational standard. The results speak for themselves. The program has achieved a treatment success rate is almost 95%, on par with the best outcomes reported globally. This is a testament to dedication of frontline health workers, the strength of multi-agency coordination, and the resilience of the Rohingya community. The role of the global platform. Today, the global platform provides us a crucial opportunity to mobilize resources for scaling up, screening, and treatment, to share best practices from the humanitarian settings, to advocate for equitable access to life-saving hepatitis C medicines, and the strengthen research collaboration for better epidemiological understandings. We must recognize that elimination of hepatitis C is not only the clinical goal, it is a matter of health equity and humanitarian dignity.
Thank you.
Call of action, I would like to conclude with these three calls. First, invest in hepatitis C programs in humanitarian settings. No population should be left behind. Second, expand access to affordable diagnostics and DAS through global partnerships. Third, integrate hepatitis C into broader primary healthcare and US Upazila health complex frameworks within the refugee responses. we have also some shortage of funding for Asia, RCCE, counseling, awareness staff, and secondary infection during the under 11 child treatment. And I think we already taken much time. Thank you.
Thank you very much. Very important comments. I greatly appreciate them.